The following podcast is part of a certified educational activity titled How I Think, How I Treat, Individualizing RCC Therapy in the Era of Immuno-Oncology, featuring David F. McDermott, MD, from the Beth Israel Deaconess Medical Center in Boston, Hans J. Hammers, MD, PhD, from UT Southwestern Medical Center in Dallas, and Nizar M. Tanir, MD, FACP, from the MD Anderson Cancer Center in Houston. Access the entire activity and complete the post-test at peerview.com/TKZ860. Downloadable slides and practice aids are also available. Thank you for listening to PeerView Podcasts. We greatly appreciate your support and would like to hear from you. Can we ask for a favor? Participate today in a short 1-minute survey at www.peerview.com/podcast survey to share how podcasts play a role in your medical education routine. Again, that's www.peerview.com/podcast survey to participate. And now, on to today's podcast.
Welcome to How I Think, How I Treat, Individualizing RCC Therapy in the Era of Immuno-Oncology. Tonight we'll explore the latest updates and therapeutic options for advanced kidney cancer and explore strategies for choosing optimal and effective treatment plans. I'm Dr. David McDermott from the Beth Israel Deaconess Medical Center in Boston, and I'm pleased to welcome my colleagues, Dr. Hans Hammers from UT Southwestern Medical Center in Dallas, and Dr. Nizar Tanir from the MD Anderson Cancer Center in Houston. So here's tonight's agenda. We'll focus on how I think and how I treat sessions on dual immunotherapy, immunotherapy plus TKI combinations, and future directions. Let's get started. So one of the important things to think about when seeing a patient in clinic for the first time with advanced kidney cancer is what's their prognostic risk group. The risk scoring system developed by the IMDC is the primary risk group that we use in clinic and was used for many of the trials that we'll discuss today for stratification. It has 6 criteria shown here, including performance status, time to diagnosis, hemoglobin, calcium, neutrophil, and platelet levels. And patients are ranked into 3 categories, favorable, intermediate, and poor, based on the number of risk factors they have at the time of therapy. So the standards of care for advanced kidney cancer in 2020 have dramatically changed over the last couple of years, with increased options for first-line therapy for patients with clear cell histology. Now, for those patients with favorable prognostic risk, the preferred regimens include axitinib and pembrolizumab, as well as the old standards pazopanib and sunitinib. Other recommended regimens include nivolumab and ipilimumab, axitinib and avelumab, and cabozantinib. Under certain circumstances, active surveillance can be appropriate, as well as axitinib or high-dose IL-2. For the poor and intermediate risk patients, there are a number of other options, including nivolumab and ipilimumab, axitinib and pembrolizumab once again, and cabozantinib, as well as other recommended regimens as listed here. Now we'll talk about recent data involving dual immunotherapy approaches for patients with untreated metastatic kidney cancer. And Dr. Hammers will take us through the data. Hans?
Thank you so much, David. So this is the pivotal trial that led to the approval of dual immune checkpoint inhibition, i.e. the PD-1 inhibitor nivolumab and the CTLA-4 inhibitor ipilimumab. This was a trial that pitted this particular combination at a low dose of ipilimumab versus sunitinib at standard of care. And these were patients primarily actually for the primary cohort that led to the approval of intermediate and poor risk patients. There were favorable risk patients allowed on this study. And while this regimen is not FDA approved, we do have data worth discussing in these patients. Also, it's important, patients who were included had to have a clear cell histology or better clear cell component, if you will, and the the primary endpoints, the power for these were actually split across three co-primary endpoints of progression-free survival, overall survival, and objective response rate, with the majority of the power dedicated to overall survival. So this study actually led to the approval of this particular combination in 2018, and so this is one of the immunotherapy combinations for which we have actually the longest follow-up, if you will, and the most recent one is the update with the minimum follow-up of 42 months. And if you look at the response rate, if you look at the median overall survival, you can see that we have reached that now with 47 months for patients with intermediate and poor risk disease treated with nivolumab, ipilimumab, versus 26.6 months for sunitinib. So a 20 months improvement in overall survival, which was certainly very significant, with a hazard ratio of 0.66. The progression-free survival was numerically better for nivolumab, ipilimumab over sunitinib, but because of the pre-specified power distribution, if you will, it was never statistically significant, with 11.6 months for nivolumab, ipilimumab versus 8.3 months for sunitinib. This is the most recent update on overall survival and progression-free survival at ESMO 2020. Here you can see in curve format, if you will, the overall survival benefit of this particular regimen, which leads to a nice separation and a maintained separation of these two curves, with a median overall survival of 48 months versus 26.6 months. And on the right, you see the progression-free survival curve. And it's not just the median that we look at, which is numerically favoring nivolumab, ipilimumab, but it's also something that may look like a tail at the end of the curve, where some patients have probably some durable benefit and may not progress for quite some time, or may never progress. We don't know that yet for sure. But that's certainly very reassuring. That's what we would like to see with immunotherapy. So these are the response rates at 48 months. And if you look at the middle column, these are the intermediate and poor risk patients with an overall response rate, not much change from the initial reporting, of around 42 months versus 27 months for sunitinib. Within those 42%, we have 10.4% of patients achieving a complete response rate, which until then was very high for upfront regimen in renal cell carcinoma, with a PR rate of 31.5%. Ongoing responses are 65.2% versus roughly 50% for sunitinib. So again, indicating that the quality of response might be different. To the right, you see the favorable risk group population, and here you can see that the response rate in this trial was lower than with sunitinib. So roughly 30%, whereas a little bit more than 50% of patients had a response on this particular regimen, but nonetheless 12% of patients also achieved a complete response, indicating that a subset of these patients can clearly benefit from this approach as well. The overall likelihood that you respond to this regimen might be less in favorable risk patients, maybe because these tumors are not as inflamed as patients with intermediate and poor risk disease. Nonetheless, this data set fuels long discussions actually with favorable risk patients. What is the best approach, if you will, and that's one of the reasons why this regimen at least is an option by the NCCN guidelines for favorable risk patients. On the left, you can see essentially both cohorts combined as the intent to treat analysis group. This is the duration of response, again, broken down by intermediate and poor risk in the middle and favorable risk on the right side. And the primary reason why I want to show you this is that it shows that patients who actually respond, it seems that their behavior of the response, the benefit and durability of the response seem to be very similar across the risk groups. If you're intermediate poor risk, the curve looks very similar to the favorable risk group. Again, indicating that if you respond, that the quality of response might be actually quite similar. This is another way to look at this. These are swimmer plots for patients who had a complete response. Looks very similar for patients who had a response in general. So clearly patients who are in the very first block on the left with intermediate porous disease, who are still on therapy in yellow. And then you can see the middle set of blocks with patients who were on therapy as indicated by yellow and are now coming off the therapy, not because of progression necessarily, but also often because of particular side effects. And these patients have ongoing responses and don't need immediate subsequent systemic therapy, creating something that we call the treatment-free interval, certainly something that's of great interest. And I would say one of the particularities about this trial is you can respond. You may come off therapy because of side effects, for example, but then you may have a really long period of time where you don't need any systemic therapy. And if you look on the right, you can see that there's a very similar behavior of that in patients with good risk disease who experience complete responses, again, ongoing responses, or being off treatment with continued benefit. If you expose patients to immunotherapy, you are certainly putting the patient at risk for, in particular, autoimmune side effects. And here you can see that most of these side effects tend to be really clustered or occur in the very first 6 months. So typically, if you deliver these combinations with just 4 treatment doses followed by nivolumab monotherapy, typically most of these side effects occur within the first 3 to 6 months. And if you go beyond that, it's much less likely to experience, in particular, high-grade side effects. So it's really the first 4 to 6 months that you have to watch and follow patients very closely and potentially intervene for typically immune-mediated side effects. These are my take-home thoughts on dual immunotherapy. So in my mind, dual immune checkpoint inhibition is a treatment that delivers essentially or targets the immune system, modulates it in 2 different ways that seem to complement each other, and is probably one of the most potent immunotherapies that you can deliver in 2020. It is defined by its durable responses. It has the potential for treatment-free intervals and opportunities for stopping therapy. And my bias so far is that maybe the CTLA-4 component may actually be necessary to maintain long-term benefit. That's something that's still up in the air to some degree. We have to see how other combinations that just offer PD-1 monotherapy, in this case in combination with the TKI, how they will, if you will, turn out over time with longer follow-up. But the price that you pay for 2 agents that modulate the immune system, you do have a higher immune-related adverse event rate, typically in the range of 30 to 40%. That is significantly higher than the roughly 15% or so of patients that require steroids. So roughly 30 to 40% of patients require steroids for nivolumab, ipilimumab, whereas 15% of patients or so receiving either nivolumab, pembrolizumab, or other PD-1, PD-L1 agents alone. So how I use dual immunotherapy. So in my practice for intermediate porous patients, it's actually one of my favorite regimens up front. In particular, if I look at a patient where I want to really focus on the potential for long-term durable responses, in particular fit younger individuals, that's a certain priority. And for favorable risk patients, I do consider it, I do have discussions with patients about it, and we will try to weigh the risk and benefit analysis in this case. Many patients, even as favorable risk, would like to often engage in a therapy that may lead to very durable responses. This regimen was studied in the second line, or better, in patients who progressed on PD-1 monotherapy. It has a response rate, but that response rate is low, of around 15%, and it can be considered in select patients, but it's probably best used up front. Again, because of the higher rate of immune-related adverse events, patient education and close follow-up, in particular in the first few months, is essential. And with that, I would like to open up for potential questions.
Well, thank you, Dr. Hammers. A fine summary. Let's talk about some of the questions that we're getting from the audience. When you talk, you mentioned in your talk about immune-related adverse events and the importance of patient education. When you're having that conversation with your patients, what do you tell them about what to expect?
It's a very good question, David. So I generally talk about worst case scenarios, really important side effects that require immediate reporting and potential interventions, such as diarrhea, colitis, inflammation of the colon, difficulty breathing, pneumonitis, headaches with inflammation of the pituitary gland. I talk about liver function tests that can get elevated, indicating inflammation of the liver, for example. And we also talk about potential muscle aches. It's a rare side effect, much more rare than the others, but they can indicate myositis or an inflammation potentially of the heart. I also talk about side effects on the endocrine system, to some degree separate than the others, because often they can lead to irreversible side effects. So for example, we do see in a relatively large proportion of patients the need to supplement them with thyroid hormone, for example. Much less common is the development of type 1 diabetes, less than 1% chance for that. But these side effects tend to be irreversible. So we can cause potentially irreversible side effects, which is different than the others that I mentioned earlier that typically respond to steroids. And I put them into context that really the most common side effect that patients will feel and experience are actually typically just mild fatigue and some itching and a mild skin rash. These are the most commonly experienced side effects. And if they get some of the more serious ones, they often don't experience them for long. Patients start on steroids typically within a few days. These side effects typically improve quite nicely, which in my opinion leads to the significantly improved quality of life over what we typically see for patients chronically exposed to a tyrosine kinase inhibitor.
Right, that was going to be my next question about quality of life. So, and you sort of answered it, which is the relative impact of these side effects, these regimens on quality of life. What did you see in the Checkmate 214 study as it relates to quality of life impact of IPI and Nivo?
Right, so there were patient-reported outcomes. A patient were given a questionnaire, and patient answered them either on the Sunitinib or on the immunotherapy arm, and there was a clear difference and clinically meaningful difference in the way patient felt with regards to these questions and potential symptoms and side effects, favoring immunotherapy. So while these side effects can be severe and may need to have immediate intervention and treatment with steroids, overall patients tend to feel better. In fact, the quality of life tends to improve over baseline. So if everybody was normalized to zero, then tendency-wise is that the patients actually felt better, probably because they were also responding as they were longer on the studies. Versus a typically deep dip in quality of life initially with these tyrosine kinase inhibitors. There's some improvement over time as patients get used to these side effects, better management, maybe some dose reductions, but there is a significant difference between the two.
And we had a discussion earlier about the IMDC prognostic risk scores and, the indication for IPI-NIVO being in the intermediate and poor risk group. How often are you factoring that risk stratification in your decision making? Do you talk about it with patients as if they're in a good risk category? And if so, how do you explain the decision tree there?
Yeah, very good question. So I certainly do that. And in fact, the longest discussions I have with good risk patients, simply because I tend to have more treatment options than patients who don't, and can range from surveillance to surgery to radiation to just tyrosine kinase inhibitors to combination with PD-1 inhibitor or even nivolumab, ipilimumab, as I mentioned earlier. And they have different flavors, if you will, a different set of aggressiveness, if you will. The truth is, good risk patients do well almost no matter what we do. They tend to live for quite some time. It's a different biology. So again, typically patients completely asymptomatic, low tumor burden, no lab abnormalities, often recurring years after the initial diagnosis. So it's a different set of patients. Intermediate and poor risk patients, these patients require treatment. The main question is, do I feel they should get the combination immunotherapy, or are they at such high risk where any type of progression would risk them of not being able to get, let's say, second-line therapy, for example? Then that might be a time where I may look at VEGF inhibitors. But typically for intermediate and poor risk patients, that's the way it's FDA approved, and I have the least discussions about this in particular.
Terrific. Dr. Hammers, thanks for sharing your insights. We certainly appreciate it, including the latest data. So let's shift gears to the other dominant approach in the front line, which is essentially a combination of the old first-line therapy, VEGF blockade with VEGF TKIs, and the old second-line therapy, which is PD-1 blockade with nivolumab. And we'll shift to Dr. Tannir from MD Anderson Cancer Institute, who will talk about the updates in immunotherapy plus TKI approaches. Thanks for joining us, Dr. Tannir.
Thank you, David, for the kind introduction. So I would like to review with you 3 trials combining, as David mentioned, a VEGFR TKI and a PD-1 or a PD-L1 antibody. And those 3 regimens, those 3 trials are first Keynote 426, and this is the study design. It was a large phase 3 trial with similar eligibility criteria to what you heard from Hans about Checkmate 214, metastatic clear cell RCC, no prior therapy, and they used the same stratification of IMDC risk as well as region. Different from the Checkmate 214, the co-primary endpoints of Keynote 426 were OS and progression-free survival in the intent to treat. That means in all the patients, in the ITT, all the patients enrolled on the trial, and there were 861 patients enrolled. And you see here the 2 treatment arms are shown here with their dose and scheduled. Pembrolizumab, 200 milligram intravenously every 3 weeks, plus axitinib, 5 milligram twice daily, and sunitinib given at the standard dose and schedule. And you'll see now I'm going to show you the latest data that were presented at this year's ASCO a few months ago. And here are the couple of markers. First, for the overall survival, again, in the intent to treat population. And in blue, dark blue there are the patients treated with a combination of pembrolizumab plus axitinib. And the orange curve represents patients treated with sunitinib. The median OS for the combination arm was not reached and was approximately 36 months for patients treated with sunitinib, for a hazard ratio for the difference of 0.68, and that was a significant difference in OS between the 2 treatment arms. And you can see here at 12 months, the landmark analysis, and at 24 months, the probabilities of OS being alive at 12 months, 90% versus 79%, and 24 months, 74% and 66%. And just to note that the minimum follow-up here for the updated data was 23 months, whereas it was around 12 months when the data was presented for the first time at ASCO GU of 2019. Now, looking at the couple of markers for PFS, the other co-primary endpoint, again, in the intent to treat population, you could see clear separation early on from around 3 months in favor of the combination of pembrolizumab plus axitinib. The median PFS for the combination was 15.4 months, and the median PFS for sunitinib treated patient was 11.1 months. Again, this was a significant difference between the 2 treatment arms with a hazard ratio of 0.71 and a narrowed 95% confidence intervals. And again, here, you see the landmark analysis for PFS at 12 months and 24 months. So this slide shows you the summary of responses. Again, in the intent to treat population, approximately 60% of the patients treated with a combination of pembrolizumab plus axitinib achieved a major response, compared to around 40% of patients who achieved a major response with sunitinib. When you look now at the breakdown of how many patients achieved CR and PRs, you could see 8.8% of patients had a CR with the combination versus 3% with sunitinib. Now, I think it's important to look also at the data from the updated results 4 months ago at ASCO, because for favorable risk, the data differ now over time, has evolved compared to the initial primary analysis that was presented at ASCO GU in 2019. So here now, looking at favorable risk, you see the Kaplan-Meier curves for OS. The two treatment arms curves are intertwined. And again, at 24 months, landmark analysis, 85% of the patients on pembrolizumab are alive versus 88% with sunitinib. Looking at PFS, again, now for favorable risk, you see that there is some separation of the curves, and you can see also the probability of being progression-free at 24 months is 45% with the combination versus 35%. However, when different from the initial analysis, when you look at the hazard ratio for OS for favorable risk is 1.06, and it's a wide confidence interval for OS, and the same wide confidence intervals for PFS for the two treatment arms. And this is important to note because at the initial analysis, the combination of pembrolizumab plus axitinib performed better, had superior PFS and OS with pembrolizumab compared to sunitinib. But now with an updated, with further follow-up, longer follow-up, there is inconclusive evidence to show that OS and PFS were superior with a combination. Now, response rate was higher with the combination. 70% or so of patients receiving pembrolizumab axitinib achieved a major response compared to 50% with sunitinib, and the CR rate with the combination was 11% versus 6% with sunitinib. Now, looking at the intermediate risk, poor risk, again, here you see separation for OS, and the median OS for patients with intermediate risk, poor risk treated with the combination was not reached, and it was 28.9 months with sunitinib, and the hazard ratio for the difference is 0.63 for OS between the two treatment arms. When you look at PFS now, the hazard ratio for the difference between the two treatment arms is 0.79. The confidence intervals are under 1, and the median PFS for intermediate risk, poor risk patients treated with the combination was 12.7 months versus 8.3 months with sunitinib. The ORR for the combination, again for intermediate risk, poor risk, was approximately 56% versus approximately 35% with sunitinib, but the CR rate was 8% with pembrolizumab versus 2% with sunitinib. Now, shifting gear to the other regimen that was FDA approved in May of 2019. This is the study design for Javelin 101. It was a large study, again, phase 3 trial, similar eligibility criteria to the other two trials we just saw. But the stratification is a little different here, and they used, instead of the IMDC risk, which you heard about, they used ECOG as one of the strata, and then region again as with the others. And again, the difference here also is the endpoints that were used. The two co-primary endpoints for this study were PFS and OS, not in the intent to treat population like we saw with Keynote 426 earlier, but in PD-L1 positive patients. That is, in patients whose tumors were positive for PD-L1, the way defined in this trial. And the two treatment arms are shown here with avelumab. Now, this is now a PD-L1 inhibitor, not a PD-1 like the other two trials, given at 10 milligram per kilogram intravenously every 2 weeks, plus axitinib 5 milligram twice daily, sunitinib given at the standard dose and schedule, as we saw in the other 2 trials. And here is the Kaplan-Meier curves for PFS. And Again, for PD-L1 positive, there was significant difference between the two treatment arms, with the median PFS for the combination of avelumab plus axitinib 13.8 months versus 7 months with sunitinib. This had a stratified hazard ratio of 0.62 and a significant p-value. But it is important to note that the OS data did not, that the trial did not meet its OS data for the PD-L1 positive population, although the updated data that was published in the Annals of Oncology a few months ago showed that by subgroup analysis, patients with poor risk disease had a superior outcome with the combination of avelumab axitinib, but not overall patient population, and not the PD-L1. Only poor risk patients had an improved OS outcome with the combination. Now, when you look at the response rate, similar to what we saw earlier, the combination of a TKI, axitinib, plus the PD-L1 antibody here in this instance produced a response rate of approximately 56% with a CR rate of 5.6% with avelumab axitinib versus 27% objective response rate with sunitinib and a 2.4% CR rate with sunitinib. So one would like to see if with longer follow-up, the OS endpoint, whether the trial will reach a positive endpoint for OS. That remains to be seen, and we can discuss that later on after we review all this data. Now, shifting gear to the third regimen that was actually read out a few months ago, and the results were presented at this year's ESMO. This is the Checkmate 9er. Similar eligibility criteria. Again, we're talking about patients with advanced clear cell RCC who are treatment naive. Stratification was similar to what we saw before, except here they added another stratum, and that's tumor PD-L1 expression. So 3 strata used here: IMDC prognostic score, PD-L1 expression in the tumor and the region. And the primary endpoint was PFS, and the key secondary endpoint OSS, response rate, and safety. And the 2 treatment arms are shown here. Nivolumab was given at 240 milligrams intravenously every 2 weeks, plus cabozantinib 40 milligrams daily. Again, it's important to note that the dose of cabozantinib in this trial was 40 milligram, not 60 milligram, which is the starting dose when you give cabozantinib as monotherapy. And the dose of sunitinib was, shown here, the standard dose and schedule. And here are the Kaplan-Meier curves for PFS. Again, we're talking here about all patients. And the median PFS with the combination was double the median with sunitinib, 16.6 months versus 8.3 months. This had a hazard ratio of 0.51 and a narrow confidence intervals and a significant difference between the 2 treatment arms. Now, here are the Kaplan-Meier curves plot for OS. The median OS for the combination of nivolumab and cabozantinib was not reached at the time of data lock and presentation of the data here, and also was not reached for sunitinib. The hazard ratio for the difference in OS between the 2 treatment arms was 0.6 with a narrow confidence intervals and a significant p-value. Now, here is the summary of the responses for each arm. The combination of cabozantinib plus nivolumab produced a response rate of 55.7%. Again, reminiscent of what we saw with the other 2 regimens combining a TKI and a PD-1 or a PD-L1 antibody. The CR rate was 8%, and for sunitinib, the ORR was 27%, and the CR rate was 4.6%. I think it's important to draw your attention that as best objective response, the nivolumab plus cabozantinib produced a progressive disease rate as best response only 5.6%. That's important because we will discuss this, how I think and how I treat our patients with first-line therapy. This piece of data would come to be important when choosing a regimen. The median time to response here is 2.8 months with the combination versus 4.2 months with sunitinib. And again, a much longer median duration of response with the combination, as you see here, 20.2 months versus 11.5 months with Sunitinib. So my take-home thoughts on the immune checkpoint inhibitor plus a VEGFR TKI. Obviously, what we saw from the three regimens, pembrolizumab plus axitinib, avelumab plus axitinib, and the latest one entering the first-line space, nivolumab plus cabozantinib, we saw an improved PFS, a high ORR, and at least for two regimens, pembrolizumab plus axitinib and cabozantinib plus nivolumab, an improved OS. But this was not met, as I mentioned, with avelumab axitinib at the time the results were presented for Javelin Renal 101. These trials with a TKI plus a VEGF, TKI plus a PD-1 or PD-L1 antibody obviously have now looking for a longer follow-up, but the follow-up remains shorter with these TKI and PD-1 or PD-L1 regimens compared to what you heard from Dr. Hammers with Nivo-Ipi from Checkmate 214, which remains the trial with the longest follow-up of any trial in the first-line space, with, as you saw, a minimum 48 months follow-up for Checkmate 214 with Nivo-Ipi. So we will see if those results that I showed you will change over time when we get to a 4-year or 5-year median follow-up. Obviously, the advantage of one of the advantages of giving a TKI plus a PD-1 or PD-L1 here is a lower immune-related adverse events due to the fact that you are not giving two potent immune checkpoint inhibitors. But the caveat is there is overlapping toxicity with a TKI causing diarrhea, which can confuse the picture. Is the diarrhea caused by the VEGFR TKI, or is it caused by the immune checkpoint inhibitor? And also the limitation or the drawback of giving a TKI is the chronic toxicity that patients can experience over years, because obviously the axitinib or cabozantinib in these regimens is given without a date of discontinuation, as we saw with, for example, ipilimumab, where you give only 4 doses. So I think that one people have to really keep that in mind and have to factor in a chronic toxicity when you're dealing when you're given a TKI plus an immune checkpoint inhibitor. So how I think and how I treat and how I use a TKI plus a PD-1 or a PD-L1 antibody, I think it's fair to say now that of those 3 regimens that I showed you, the 2 that have OS advantage are pembrolizumab plus nivo-cabo. So really, I think the field is now leaving on the sidelines the avelumab axi, even though it was approved in the US. But as you saw from the NCCN guidelines, it is not the preferred regimen in first line. So how do I choose? When do I give a PD-1, let's say pembrolizumab or nivolumab plus a TKI, either axitinib or cabozantinib? I think it is fair to say that there are patients who, while you are really aiming for that tail at the end of the curve with the Nivo-Ipi, there is the caveat of unfortunately having in some patients a high progressive disease rate with the Nivo-Ipi, and that's around 20%. So you really have to make sure that you think the patient is going to be able to get a second line if they do not respond to the first line. So that's one scenario, one situation where one could use a combination of a TKI plus a PD-1 antibody. I think the data from Checkmate 9, in the interest of time, I didn't show you the quality of life, but the quality of life actually was good, favored cabozantinib plus nivolumab over sunitinib. Again, probably because the dose used was 40 milligram, which was very tolerable. But I think it's also fair to say that the results of Checkmate 9 were not much different when it comes to efficacy, whether it's response rate, CR rate, or PFS or OS compared to pembrolizumab. So the 2 regimens are basically comparable in efficacy. One has to choose which one would you choose of the 2 when you're thinking about a TKI plus a PD-1 antibody. I think if you use a TKI plus an IO in the first line, or you use an Nivo-Ipi in the first line, and the patient progresses or outright progresses or progresses after an initial response, the standard of care right now is to give another TKI. And we can discuss that later on. If there is a role of continuing with a PD-1 or a PD-L1 blockade after already the patient been exposed to immune checkpoint inhibitors in the first line. The standard of care right now is to give only monotherapy with the TKI that was not given in the first line. I think it's important to educate patients. I think I cannot overemphasize this point. I think you heard from Dr. Hammers that there is a high immune-related adverse event with when you give a dual nivo-ipi, for example. Same thing here, although the IRAE is less with the TKI PD-1 antibody, but really to have educate the patients. And I would say educate the staff, educate the physicians in the community, and educate the nurses who are on the front line. What we can discuss that later. I think it's important. The sooner the patients report to you, give you an alert that they're experiencing, encountering adverse event, the sooner you intervene, you implement a strategy to mitigate the adverse events, the better the outcome. So I really think this is a crucial point if we're going to be successful in administering these therapies. Back to you, David. Thank you very much for your time.
So thank you very much, Dr. Tanier. An excellent summary of a lot of data. So you addressed some of the questions we're getting from the audience in your talk, but let's give you a chance to sort of refine some of those answers. So, obviously one big question now that we have several IO TKI options available, when they're all available, I guess the question is, how will you select between them? So let's say for the sake of this question that Nivo-Cabo is available. What will you go with in frontline patients when you want to choose IO and TKI therapy?
Yeah, David, I think this is obviously what we're grappling with in real world. Obviously, whenever you have a clinical trial, trial participation is what we do at MD Anderson, and I'm sure at your institutions, both of you, David and Hans. But off protocol, I like Hans for patients with intermediate risk, poor risk, clear cell RCC. My favorite regimen, my first line regimen remains nivo-ipi. I think, and the reason is I'm aiming for the tail at the end of the curve. I'm aiming for those CRs that are more than 10%, whether you're looking at intermediate risk, poor risk, or ITT or favorable risk, you got higher than 10% CR rate. And 80 to 90% of those CRs are durable. And even if you look at PRs that are deep, again, I think the advantage of giving nivo-ipi for these patients with intermediate risk, poor risk is that durability of a major response, whether it's CR or DPR. So that's what one of the goals of care, one of the goals of therapy is to basically, achieve CR that's durable and hopefully break the barrier of cure. That's what we really need. That's what our patients want. But of course, there are some situations. We know very well that many patients do not respond to first-line therapy, and then they have to go on to second line. So if I have a gestalt feeling or a sens clinique, as the French say, of fearing that the patient may not get to a second line. And if I give them that nivo-ipi first line and they may not respond. And we do not have right now biomarkers to tell us who will respond to first line, whether it's nivo-ipi or a TKI PD-1 antibody. We really rely on our clinical sense, sens clinique. And so I think if you sense that the patient is going to rapidly progress and may not get a chance to get a second line, and maybe if the patient has bone metastasis, I think that patient may be a good candidate for a cabo-nivo, for example. I would, as I said, I have not used avelumab plus axitinib except on a clinical trial. So I'm not going to discuss my choice of avelumab axitinib, even if it's FDA approved, because I don't use it. So I think it's going to be between pembro plus axi or nivo-cabo. I think the quality of life with the Checkmate Nitro was impressive, and I think that really may be a regimen to go with if you are thinking of a TKI IO.
So as far as adverse events, do you see any meaningful differences in adverse event profile from these various combinations, or are they pretty similar when it comes to treatment-related adverse events?
I think when you look at the TKI PD-1 antibody, let's say pembrolizumab versus nivo-cabo, I think the results are very similar in terms of adverse events. So I think you're going to deal, as we said, with the chronicity of giving an axitinib for years or a cabozantinib for years, the diarrhea, the hand foot, the stomatitis, the nausea, dysphonia, all those things are very similar. One I would say, though, that with axitinib, it has a short half-life of 4 hours. So if the patient is having diarrhea, you do not know if this is from the axitinib or from the pembrolizumab, you can stop the axitinib, and then because it has short half-life, within a day or two, they'll feel better. And if the diarrhea improves within a day or two, then you'll know that this is most likely axitinib that is doing that. On the other hand, cabozantinib has a long half-life of 99 hours, so it may be a few days before you're able to really tell which of the two agents is causing the diarrhea, for example. But overall, I think TKI, PD-1 antibody are going to have the same, similar adverse events. And you look at the discontinuation rate is also in the ballpark. 15% of patients discontinued either cabo or nivo or both from Checkmate 9er, and I think it's similar rates of discontinuation with pembrolizumab from Keynote 426.
Great. So let's bring Dr. Hammers back for another question from the audience on this topic. So you've just heard Dr. Tannir go through the data, particularly for favorable risk patients. So having heard that, all the data, does it change your approach as far as what you offer favorable risk patients? Are you still, having seen those results, Hans, would you still offer dual IO therapy, or are there some good risk patients who you'd prefer to give TKI and IO therapy?
Sure. So as I mentioned earlier, the good risk patients are the ones I have the longest discussions with because the classic phenotype is one with typically a small tumor burden or low tumor burden. The labs are by definition not abnormal, and they often recurred years after the initial diagnosis. So these patients are typically not with the back against the wall. Although, quite frankly, some patients actually meet the definition of favorable risk, but maybe they have actually fast-growing tumors. So that, in my book, actually puts them more at higher risk anyways, independent of these other indicators. But for the discussion's sake, so my goal really is very similar to what Dr. Tannir mentioned. Is I have a patient in front of me, and what they want is to address their cancer definitively. I want to get rid of it, so to say. And in a durable fashion. So I still offer nivo-ipi to patients, but I'm very clear about the risk and of potential immune-related side effects, and that just by, let's say, response rate, the benefit might be less. However, there's 12% patients who get a CR, or other patients with deep response who can benefit from this. A tyrosine kinase inhibitor, so typically as a monotherapy in my book, is just palliative treatment. Anyways, these patients will invariably progress, and so that would be one of the choices, or the hybrid between the two of them. And we still have to see if what the long-term outcome is in patients who get PD-1 TKI exposure. So it's a long discussion. At the end of the day, some patients will choose a regimen where they see a 55-60% response rate simply because that is what they need, maybe even psychologically. With us still being unclear about the long-term outcome data. Other patients understand that pure immunotherapy might be a higher gamble with regards to side effects. The overall chance to shrink my tumors is less, but they're looking for the long-term outcome. So I would say I offer and try to delineate some differences between the regimens. At the end of the day, it's the patient who decides typically for these patients, because they really are not with the back against the wall, and they will choose what appeals to them the most.
Yeah, so a terrific discussion. I guess without head-to-head data, which we lack making these comparisons, the discussions are longer with patients, but it's good to get into it, and it's good to hear your thoughts on how you approach it with patients, because every patient has different goals and different comorbidities and things like that. So terrific discussion. Let's move on now to talk a little bit in the remaining time we have left as far as future directions. We've heard a lot of exciting developments for untreated patients, but as we know, not every patient is going to respond to these approaches, and we can always do better creating deeper responses and longer benefit, improved survival, more remission. So how might we do that in the future? And the next trial we wanted to mention is the Cosmic 313 trial. We've talked today about PD-1 blockade and CTLA-4 and VEGF blockade, and this trial looks at putting all three of those effective approaches together, comparing the current standard of care of Nivo and Ipi and placebo versus Nivo and Ipi and cabozantinib at 40 milligrams once daily. So this will essentially look to see if we can improve on Nivo-Ipi by adding VEGF blockade in the front line. And you see here the primary endpoint being progression-free survival. So that trial is accruing as we speak. Another trial, another novel agent, is sort of an old agent brought back in a different variety, is the Pivot-02 trial, which looks at a new variation on interleukin-2, which is pegylated aldesleukin or bempeg-aldesleukin, NKTR214. This agent, this IL-2-like drug, is being combined with nivolumab in kidney cancer and a variety of other tumor types. The way this agent is modified is essentially it's the old IL-2 with the IL-2 alpha receptor, with pegylation attached to IL-2 in hopes of making it less likely that it will engage the alpha receptor of IL-2 and drive less Tregs and more T effector cells. You see some of the early response rates of this combination shown in the Pivot-02 trial, within first line over a 70% response rate, second line 29%. Interestingly, responses were seen regardless of baseline PD-L1 status, and the combination was well tolerated here. Unlike high-dose IL-2, this is given outpatient to patients, so it can be given much more safely. And based on those results, there's now a randomized trial, which is the Pivot-09 study, comparing Nivo and this IL-2 agonist Nectar-214 versus essentially the investigator's choice of the preferred VEGF inhibitor, either Sunitinib or cabozantinib. So that's another approach to frontline treatment, which may move the field forward in the coming years. Another approach that I think many of us are excited about, which is proven effective in melanoma, is now we've established PD-1 blockade works for patients with advanced disease. Can we move it to the earlier in the line of therapy? Can we move it to the adjuvant setting for patients with stage 3 kidney cancer? And you see here several trials that are ongoing. Most of these have actually finished their accrual. You see a trial with atezolizumab, pembrolizumab, the combination of PD-1 and CTLA-4 with durva and tremi, as well as Nivo and Ipi, either compared to observation or placebo. Over the next few years, we're going to start to see the results of these trials. In my opinion, sort of the next big step forward for kidney cancer could be in the adjuvant setting, bringing checkpoint blockade there. But there's obviously some downside risks, which we need to monitor closely, particularly when we're talking about combination PD-1 blockade in the adjuvant setting. We've seen this field advance in melanoma by bringing adjuvant therapy, bringing PD-1 into the adjuvant setting. Hopefully we'll see the same thing in kidney cancer. So stay tuned for that. Another novel approach to PD-1 blockade in the adjuvant setting is being looked at in the PROSPER trial. Here, patients are randomized to Nivo versus observation. So it's a pre-surgical dosing of PD-1. The thought there being the immune cells are still in the patient prior to surgery. The tumor is still in the patient. The antigens are still in the patient. So let's activate the immune system and those immune cells before taking the tumor out. So we'll see if this approach also bears fruit. And this is actually a trial that's still accruing in the cooperative group. And so when you think about sort of my take-home messages for future directions, we're seeing novel therapies, novel forms of IL-2, novel combinations. We may be entering an era with triplet therapy. We're also seeing some other approaches like HIF blockade, which we don't have time to talk about, but that's another exciting approach in the salvage setting. Adjuvant therapy could be a next big step forward. And obviously, if you have a patient with stage 3 disease, certainly consider them for one of these trials that I mentioned. But hopefully in the next couple of years, we'll continue to accelerate our progress for this disease. And when you think about sort of how I treat, what I think as far as new approaches, who should get the new combination regimens in the front line, I think most of us agree that for most patients, PD-1-based combination regimen is the new standard of care. Unless you have an absolute contraindication to immune therapy, you should probably be getting one of these two dominant forms of PD-1-based therapy. Most patients can get it safely, although there's some patients, for example, with severe autoimmune disease that probably need to stick with the old standard VEGF blockade. And as far as picking adjuvant therapy, Sunitinib is approved in this setting, but the data there is, weak at best. It's several negative trials, one a positive trial for disease-free survival, but not overall survival. So still clinical trials are still appropriate for patients in the adjuvant setting and certainly could be considered for your patients that are motivated to pursue new options. So let's get some thoughts on the faculty, on what I just presented. So Hans, how about you first? So, what's your thought about adjuvant therapies in your institution? Are you offering standard of care Sunitinib, or are you considering trials? How do you think about it when you see a new patient?
Yeah, thank you, David. Very good question. Unfortunately, kidney cancer, as you well know, has been a disease that has been littered with negative adjuvant trials, and Sunitinib, the trial, was unimpressive in the sense that the overall survival benefit was not there. It met, certain criteria by trial design, and but it's in the context of essentially the same class of drug not really being that effective. Because at the end of the day, what we want is that there is a survival benefit. Patients live longer. We cure them with micrometastatic disease, right? That's the potential benefit very early in the disease process. I do think always about clinical trials first before I would even consider Sunitinib.
Great. So Nizar, any thoughts? Do you think of this any differently than Dr. Hammers?
Well, similar to Hans' approach, I think we participated in both adjuvant trials with Atezo versus observation and Pembro versus placebo. The Emotion 10 and I believe Keynote 549. But right now we do not have an adjuvant trial. So off protocol, I think the standard of care remains observation. Like you said, I do not believe Sunitinib is an effective treatment, and I do not really prescribe it to our patients in the adjuvant setting. So clinical trials or observation, I think, would be our approach at this point.
Terrific. So going back to sort of the last question, we mentioned some of the new approaches in development. Hans, what are you most excited about in the coming years that's in developing? Something I mentioned, something that I may not have gotten into. What are your thoughts on what's next?
Yeah, so certainly what you alluded to, the interleukins in a different fashion, if you will, in the outpatient setting. We have to see what the ultimate data is going to be. It's interleukin 2. Hopefully interleukin 10 will have another shot at renal cell carcinoma. So there are many different ways to think beyond immune checkpoints per se. So I do think cytokines and interleukins, there will probably be a resurgence of some of these hopefully in the future. It's also probably worth mentioning in general, I would say, vaccination approaches. So really educating the immune system about the presence of a cancer, if that is not already a spontaneous event. So either by developing, let's say, peptide-based, mRNA-based vaccines, with very sophisticated pipelines for that, or just inflaming tumors by, for example, injecting them with activators of the innate immune response, such as TLR agonists, STING agonists, etc., similar to what we think about radiation might do. The other class of drug that you also alluded to, I think, is very exciting, although more on the palliative route, but certainly a potential salvage agent, and really very interesting with regards to its very benign side effects are the HIF2 inhibitors, so inhibitor of the transcription factor that's very much at the heart of the biology of renal cell carcinoma. And I think the data is certainly very encouraging, even for potential chronic use, since these agents are well tolerated. For Hippel-Lindau patients, for example, who have a genetic syndrome with multiple small renal masses and other tumor-like abnormalities, they seem to benefit from this class of drug as well. So I do think there are some very exciting directions.
Terrific. Nizar, any thoughts on what you're excited about in development?
Yeah, I think obviously the Pivot-09 is a phase 3 trial looking at the combination, as you showed, David, this novel piglet IL-2, Bempeg, aldesleukin, or Bempeg short, or NKTR-214, in combination with nivolumab versus a TKI of choice. I think the trial is a 600-patient phase 3 trial with two co-primary endpoints, ORR and OS. It's a hierarchical, sequential, endpoints, first ORR, then OS. The trial is close to reaching its target accrual, the 600 patients. I think either at the end of this year or first quarter of next year, the trial is hopefully will finish its accrual. We'll await the results to see if this novel agent can be effective in combination with nivolumab.
So once again, I'd like to thank my colleagues, Drs. Tannir and Hammers, for a great discussion tonight. We thank you very much for joining us. I hope you and your families stay well and you have a good evening. Thanks again.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/TKZ860. This activity is supported through an educational grant from Bristol Myers Squibb.